Hello everyone and welcome to CRAMSURG, clinical research appraisal and methodology for surgical trainings, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinions and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Saba Balasubramanian, Adam Haig, Ben Wood and Josh Lau, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber. Welcome back everyone. Today we will be having a look at a paper recently published in BJS entitled Low Pressure versus Standard Pressure Laparoscopic Colorectal Surgery, the PAROS trial. Professor Saba Balasubramanian is then going to talk about p-values and confidence intervals, core essential topics for anybody reading or being involved in research. We have a couple of special episodes coming up in June and July, so stay tuned.
So hi everyone, I'm Sadia, one of the surgical visitors working at Huddersfield Royal Infirmary, and I'm here with my registrar, Mr. Gio Perrin, and we'll be discussing a paper on low pressure versus standard pressure laparoscopic colorectal surgeries, which is a PAROS trial, and it's a phase 3 randomized controlled trial. And this was recently published in the British Journal of Surgery in March of 2021. And now Gio will take you through the background.
Yeah, just a quick quote about the reasons why this sort of paper was born. Well, we do know that the laparoscopic approach to colon surgery is supported by a fair amount of evidence. This is both in terms of recovery and reduced pain post-operatively. We discuss the applications of this to emergency surgery, and I invite you to have a look at our episode 9 if you're interested. Worth mentioning here, in 2002, the European Association of Endoscopic Surgery recommended to insufflate at the lowest possible pressure that will still provide sufficient exposure to perform your operation. And this is regardless on what operation you're doing, so it's not specific to colorectal surgery or anything in particular. The main advantages of using a lower pressure would be reduced pain and potentially shorter hospital stay. And this supposedly is driven by a reduced stress to your diaphragm, your lungs, and obviously reduced stretch to your abdominal wall. What we do not know for sure is whether it is equally safe or if it is more difficult, and if the views are equally good. In this particular setting, the air seal, which is a particular type of insufflator to generate your pneumoperitoneum, is tested in this particular trial. It's supposed to maintain your pneumoperitoneum more stable and allow a sort of more controlled smoke evacuation, particularly when you're using energy devices and suction. So ball back to you, Sadia.
Thank you. So just discussing the aims of this trial, which was to see what's the impact of low pressure pneumoperitoneum during laparoscopic colectomies. And the patients that were chosen were the ones undergoing elective laparoscopic colectomy. And the intervention was low pressure pneumoperitoneum, which was compared with the standard pressure pneumoperitoneum. And the primary outcome that was assessed was the duration of hospital stay in these two arms. And secondary was what was the post-operative pain, how much analgesia was consumed by these patients, and was there any difference in the post-operative morbidity in the two arms. Back to you, Gio.
Yeah, so this was a double-blinded randomized control trial which was conducted in a single center with 6 surgeons involved at Bordeaux University Hospital in France between January 2019 and May 2020, so a relatively small time frame for recruitment. Patients were randomized in a 1-to-1 fashion to 2 treatments, either low pressure, 5 to 7 millimeters of mercury, or standard pressure, 12 to 15 millimeters of mercury. No blocks were used and no minimization was used in this randomization. This is designed as a superiority trial, and I invite you to have a look at our previous teaching session from last month if you want to know more about this. And the aim is to demonstrate a 1-day difference in length of stay in favor of a low pressure pneumoperitoneum. So let's move on. The included patients were 18 years old or older, not pregnant, and only a procedure that started with a laparoscopic or robotic intent was allowed to be included. Right or left colectomies without a defunctioning stoma were the pretty much only procedures allowed. So no subtotals, no cecectomies or anything else. Only elective procedures were allowed, and a variety of malignant and benign pathologies were included. So here we've got UC, Crohn's, together with large polyps, together with known cancers. The surgeon was allowed to perform no other procedure apart from the colectomy, with the exception of appendicectomies and liver biopsies that could be performed concomitantly. And Sadia is going to talk us through the timeline of the study.
So this is just a small chart which shows the timeline of the surgery. So all the red bits are the primary outcomes and the yellow bits are the secondary outcomes. And the patients were randomized into two arms, either in the low pressure pneumoperitoneum, which was 10 millimeter of mercury, or the standard at 12. And this was done a day before the surgery. And the patients read their surgery, and then the primary outcome was to see with a preset criteria for discharge, that whether if the patients had pain or how much pain they had, and what was the analgesia consumption, if they had any nausea or vomiting, if there were any temperature spikes of more than 38 degrees, or how quickly they resumed their normal diet and mobilization. And in secondary outcomes, it was assessed that what was their pain score according to VAS, which is the visual analog scale, and what were the analgesic requirements at 2, 8, and 24 hours. And this was according to the ERAS protocol. And these patients were followed up for a month after post-operatively. Back to you, Gio.
So as you can see from the flow chart, 151 patients were assessed for eligibility and 138 were ultimately randomized. 69 were allocated to low pressure and 69 to standard pressure, as you would expect in a one-to-one fashion. 58 in the low pressure received their allocated intervention, and worth noting here, 9 of them were converted to a standard pressure as visibility was not good enough. They had 2 conversions to open surgery in either group. As you can see, we have a few exclusions after randomizations, and most of them for patients that were wrongly included because the wrong procedure was picked up, either a total colectomy or an appendicectomy, as you can see from the chart. Some of them could have potentially been prevented. So 62 ultimately ended up being in the low pressure and 65 in the standard pressure. None of them were lost to follow-up, but again, follow-up here is only 30 days. So ball back to you, Sadia.
Just talking about the results, they analyzed 127 patients, and what they saw was that in group A, which was the low pressure group, the mean hospital stay was 3 days compared to 4 in the other group, and which was quite significant. And then the secondary outcome, which was assessed, was the pain score, and what they saw was that initially in the first 2 hours post-operatively, group A, which was the low pressure group, complained of less pain as compared to the ones in the other group. And as we can see in this table, at 2 hours, 76% of the patients in group A complained of less pain as compared to 59% of the patients, which was a significant finding. And then again, at 8 hours, reassessed, 87% of the patients were still complaining of pain scores of 3. And in group B, there were 72% of the patients, which was also a significant finding. But at 24 hours, what they noted was it was almost the same amount of patients complaining of pain. So it lost its significance there. And this is just a graph depicting what we've already spoken about, in which the blue line depicts the low pressure group and the red line depicts the standard pressure group. And as you can see, 76% versus 59% of the patients complained of less pain at 2 hours, and then 8 hours, it was still significant. But by the time it was almost a day post-operatively, it was almost the same. Did you?
Yeah, so just a quick glance at their surgical results. So as you can see, surgical morbidity was comparable between the two groups. So 6 out of 62, 11 out of 65 patients with no statistically significant difference. And as you can see, leak rate was, well, I would say that there is a tendency towards it being slightly higher in the standard pressure group. However, there's no statistically significant difference throughout the board in total. If you look at medical morbidity, that is again comparable. And finally, looking at Clavien-Dindo complications, as you can see, grade 2 complications were tendentially more common in the control arm. However, no significant really difference looking at the table itself. Ball back to you, Sadia.
Thanks. So just talking about some of the limitations that was reported by the study itself, they realized that there was poor exposure with low pressure in some of the patients, so they had to increase the pressure back to standard pressure in 9 of the patients. 3% of the patients had to undergo a laparotomy in both groups, and that was either because they were unable to resect the tumor or because of the body habitus. And they also noted that the benefit of low pressure on post-operative pain was lost after the first 24 hours. And Joe will take you through the other limitations.
Yeah, just a few words about other few points that we picked up reading through the paper. Now, concerning the primary outcome, which is, as we mentioned, length of stay, we definitely mentioned that there is a difference between the two groups in favor of the low pressure. However, it's worth mentioning that the range between the two groups is quite different. It's 2 to 13 in the low pressure group and 2 to 42 in the standard pressure group. Now, Prof will correct me if I'm wrong here, but when you are performing your sample size calculations and you are aiming to detect a certain difference between the two groups, you are also assuming that the variance between the two groups is similar. And I could not find any other measures of variations of within the groups in the paper, but the range that I just mentioned. So it might be interesting to just know that as well. I'm not entirely sure where the decision to use a 1 day difference to make the sample size calculations comes from. All the literature available, or the vast majority of it, comes from laparoscopic cholecystectomies, really, or gynecological surgery, and the sort of expected difference in length of stay that comes from those papers is a fraction of a day, around a quarter of a day. So I'm not entirely sure why they chose 1 day and how previous literature informed a sample size calculation. But again, this is picking a little bit. They use no blocks and no minimization to perform the randomization. I'm not entirely sure how externally valid this can be, so how applicable it would be in a different reality, in a lower volume center, for example, or where sort of the anesthetic and analgesic protocols are not as well standardized. And finally, this is just a thought. Obviously, this study is designed and powered to detect a difference in length of stay. However, we are talking about procedures with a certain degree of mortality, about 2%, and a certain degree of anastomotic leaks, which does obviously add a significant morbidity. So I was pondering, if I were the authors, whether I would choose to first of all demonstrate non-inferiority of a low pressure versus standard pressure in terms of safety, so choosing a primary outcome that's a complication. Ball back to you, Sadia, for some conclusions.
Right. So to conclude, low pressure pneumoperitoneum in colonic resections improve postoperative recovery in shortening the duration of stay in the hospital. And then we just have a little table showing some pros and cons of this study. And thank you for joining us today, everyone.
As usual, a quick rundown of what we discussed after the presentation. First of all, with the help of Professor Balasubramanian, we clarified a couple of points. Yes, variance is definitely important when looking at any variables. However, in this context, it is, given the non-parametric nature of length of stay as a parameter, expected to have a certain variability of range. So this is probably in line with normal and should not affect the validity of the study findings. Concerning the sample size calculations, yes, this is generally informed by previous literature, However, it is more than adequate for the authors to decide what threshold they would accept, particularly in terms of superiority, when adopting a new treatment strategy such as the low pressure pneumoperitoneum. So the 1 day as a number is adequate, obviously as chosen by the authors. Concerning the nature of this study being a superiority trial, we had some discussion concerning the possibility of adopting a different approach, such as looking at non-inferiority of the low pneumoperitoneum pressure versus standard pressure using a complication as a primary outcome indicator rather than length of stay. And given the relatively poor evidence predating this trial, it would be reasonable to take that approach rather than a superiority approach. Furthermore, we discussed the possibility of assessing the success of the blinding. Authors are very meticulous in their double blinding technique. It is quite clear that patients were blinded to the intervention as well as assessors, and that the primary surgeon involved could not be discussing discharge dates with the patient. However, we highlighted how some of the discharge criteria laid down in study protocol could be open to interpretation, and we would wonder if the persons making the decisions concerning the discharge of the patients were actually unaware of the arm that the patients were on, whether that could have influenced their discharge decisions. So assessing for success of blinding in this context could have been interesting. Finally, we mentioned the importance of social and cultural biases in terms of discharging patients, the support network that those patients go back to. The discharge destination for these patients would be probably a relevant factor to take into account. A final point would be the importance of the learning curve associated with learning a colorectal resection in lower pressure settings. How feasible it would be to maintain this low pressure practice in the context of a teaching setting. Alright, I'll leave you to the presentation now. Thank you.
So that's what we're going to be talking about today, p-values and confidence intervals. Right, just to recap, I'm not a statistician, I don't have any formal qualifications, but I think these are concepts that anyone who is involved in clinical research or any research should understand, and hopefully this will help some of you who are on your way to doing research and critiquing papers. Okay, let's consider an example. So let's assume that you're doing a study, a cohort study of patients undergoing major abdominal surgery, and you're looking at risk factors for infection. So that's a topic let's assume you're interested in. And one of the factors you're looking at is smoking. And let's say that you've got some data on smokers and non-smokers. And because this is a cohort study, you have a lot more non-smokers than smokers, right? So this is not a case control study. So you're starting off with the risk factors, and then you're following patients up to see if they've had infection or not. And let's assume that these are the numbers that you've got. So you've got 600 non-smokers, 50 smokers, and you've looked at infection rates in these two groups. And you find that among smokers, 60% have had an infection. However, you've defined an infection, and 20%, so a much smaller proportion of non-smokers have had infection. Right. So there's a clear difference in infection rates. So you've got 60% versus 20%. And then you have to ask yourself the question, what does this difference mean? What does this threefold difference in infection rates mean? Is this the truth? Can you generalize this to the wider population of patients undergoing major abdominal surgery? Or could this be that this is just a chance finding? In this one study, you found a threefold difference. Right? So what would happen if you repeated the study? If you did the study another time, or third time, fourth time, up to a dozen times? Now, obviously, because these things are not fixed in stone, and nature is variable, clinical outcomes are variable, you could get a lot of different results. You could do another study and find a result and that shows that gives you rates of 50 and 30%, or you could do a study that gives you fairly equal infection rates and so on and so forth, right? So how do we get to the true rates without repeating the study 1,000 times, or without having to study the entire population of patients undergoing major abdominal surgery in a region? We've got to accept that we can never really get to the true rates. You do a study in your institute, you will find rates that are probably slightly or sometimes very different to what's reported in this particular study, right? All we can do is we can rely on estimates and probabilities. Okay, with that in mind, and assuming that this study was well designed and the cohort is generalizable, can you then say, oh, we can rely on this estimate of 20 and 60%, which is a threefold difference? And can we state that smokers are 3 times more likely to get postoperative infection? Can we do that with confidence? That's the question. In other words, are these results significant? So you've got the rates, but then you've got to decide on whether they are significant. So when we talk about significance, I think it's quite useful to just have a little think about the difference between what we call clinical significance and what is meant by statistical significance. So as you can see in this table, clinical significance answers a question whether this difference that you see is of clinical importance or clinical relevance. Whilst in statistical significance, you're looking to see if the difference is likely to be true or real, right? And clinical significance is based on your judgment as a clinician, your knowledge, value, experience, and wisdom. So you decide what is clinically important for you to recognize as something positive, and then to imply the result, and then to accept the results and incorporate them in your practice. Whereas statistical significance has to be based on statistical testing and statistical methods, right? So you might say that, right, we've seen a 40% increase in infection rates in smokers, which is a threefold increase. But the question is, how do we know this is real? To which a clinician might say, well, the study is really well done, seems to be free of bias, so it's internally valid, it's generalizable, this is the population I see in my practice, so what's the problem? I'm quite happy with this with what I consider to be a clinically significant difference in infection rates. To which a methodologist or a statistician might say that this difference that you see could still be due to chance, and therefore we need to understand the probability that this difference occurred just due to random chance. In other words, he or she is saying that you need to be doing statistical testing to ensure that this is not due to chance. So before you start contemplating a statistical test, or before you do statistical testing, you need to think about the hypothesis. So the hypothesis here is fairly straightforward. When I say hypothesis here, I mean the null hypothesis. And that would be that there is no difference in infection rates between smokers and non-smokers, right? So that'll be the null hypothesis. And I've got the table here again with the numbers that we've just discussed, and just so you can recollect the numbers. And then and take it from me that the statistical test for significance with data of this kind, which is categorical data, is done using a method called the chi-square test, right? We're not going to go into the details of chi-square testing here, but that's the test we would do. So in the olden days, we used to calculate the chi-square statistic, use degrees of freedom, and then figure out the probability of getting at least this chi-square value or more than this chi-square value from either a table or a calculator. But these days, you can run a chi-square test really quickly using an online software like SPSS. Okay, so let's assume that you've done this chi-square test, and the calculator gives you these values. It says that the chi-square statistic is 41.6, degree of freedom is 1, and the p-value that you get as a result of doing the statistical test is less than 0.01. It is actually less than 0.0001 in this particular calculation, but that's okay. So it's very, very low. So what does that p-value mean? So the p-value here means that it refers to the probability of getting a result at least as extreme as this due to chance alone. So in other words, the probability of getting a result like this or a greater difference in this is extremely low, right? On that basis, where you have a p-value that is extremely low, which is much less than 1 in 100 or less than 0.05, we have to say that if the null hypothesis is true, then this result is extremely unlikely to have occurred. Okay, which means because the p-value is extremely low, we're going to reject the null hypothesis, and thereby implicitly we say, or we will accept the alternative hypothesis, which is that smoking and infection are associated. Okay, so I hope that explains the meaning of the p-value. Now the value of 0.05 is arbitrary. It's just a convention that you say that if the chances of observing the result as extreme as this is less than 1 in 20, we'll be happy to reject the null hypothesis. Okay, some people don't like this arbitrary value and would like to go down even further to 0.01, but that's fine. You've got to a priori, before the start of the study, decide what p-value you would accept as your cutoff or your threshold. Right. So some of you might have listened to the talk on type 1 and type 2 errors, and the point to note here is that the p-value is essentially the same conceptually as a type 1 error, which is the probability of falsely rejecting the null hypothesis. Okay, and keep in mind that p-value is simply not the probability that the null hypothesis is true. When you start off a study or a statistical test to test a null hypothesis, you've got to keep in mind that you can never prove the null hypothesis. You can only gather enough evidence to reject the null hypothesis. And if you reject the null hypothesis, then you have to, then that means that you're accepting the alternative hypothesis. Another point to note is that the p-value does not reflect effect size or the strength of the association. So if you get a relative risk of say 6 or 8 or 10, that doesn't mean that your p-value will get smaller and smaller. And then the converse is true as well. And finally, you just have to keep in mind that the p-value on its own is not sufficient to judge a model. So you need something else, and that's what we're going to go on to next. If you did want to read up a little bit more about p-values, there's a really good article on the internet, free to access, from the American Statistical Society or Association on p-values, and the link is here. Right. So the other concept we're going to discuss today is confidence intervals. So let's keep the example we've discussed in mind again. We found that infection appears to increase risk of, smoking appears to increase infection risk threefold. In other words, the relative risk is 3, and we've got a really low p-value. Okay. Now this relative risk of 3 is one estimate or a point estimate, but we're not clear yet as to how precise this estimate is. Or in other words, what's the range or the interval in which most values are likely to lie? If you do 10-15 studies, what's the likelihood that you're going to get values that are around the point estimate of 3? And when I say most, in statistical terms, in statistical parlance, we refer to 95%. Okay, so what's the range or interval in which 95% of the values are likely to lie is the question. Now, could it be 2.9 to 3.1? That'll be fairly close, narrow range. Or could it be as wide as 0.5 to 10? That'll be a very wide range. Okay, and this range or interval is what we refer to as the confidence interval. we often see confidence intervals being depicted or described in forest plots, which are part of systematic reviews and meta-analysis. And you would have come across plots like these, where the squares in blue refer to point estimates from individual studies, and the lines around these point estimates are the 95% confidence intervals of that effect size in that particular study. So in this particular forest plot, you've got 4 different studies with point estimates and confidence intervals. Okay, so I've done some calculations for this particular example, and I found that the 95% confidence interval for this particular relative risk of 3 in this study was between 2.3 to 4. Now, the precise calculations are tricky. They're beyond the scope of this lecture, but we're fortunate that there are lots of software and online calculators that you can use to get confidence intervals for a variety of point estimates. So, going back to both p-values and confidence intervals, let's compare them. So p-values enable a rapid assessment of significance. If somebody's got a p-value for you, you look at it and you know straight away whether it's a significant result or not. While a confidence interval gives you a range within which the real value may lie. Okay, so it also provides you strength of the association. So you know how likely the association is going to be and how strong it's going to be, and it tells you the direction of effect. So if it's a relative risk of more than 1, you know that smoking increases risk of infection. If it's a relative risk of less than 1, 0.5, 0.7, 0.8, then you know that smoking may be associated with less infection. Okay, so the confidence interval gives you both strength and direction of the effect. Right, a couple of little points to note. So when someone says 95% confidence interval, it does not mean that the interval is 95% likely to contain the effect size. We'll never know what the truth out there in the population is going to be. So what the 95% confidence interval refers to is the likelihood that if you do 100 other studies, 95% of them will give you a point estimate that will lie within this interval. So that's what the true meaning of confidence interval is. Okay, and when you're writing a report, when you're looking at studies, it's ideal, it's encouraged by lots of journals, lots of editors that you describe both the p-values and 95% confidence intervals for any statistical method you can use. Okay. Now, the final point really is that these values, the confidence intervals and the p-values, depend on a number of factors and in particular sample sizes. So let's just take the same example again. You've got smokers versus non-smokers compared to infection as an outcome. And you know that we had 650 patients to start off with in the study. And let's just assume somebody else has done a really small study, but very similar in design and assumptions. So, and these numbers in red are from another much smaller study, but very similar in design and assumptions. Okay, and you find that the infection rates in both groups are fairly similar. It's just that the numbers are really low. So if you then compare the parameters in the larger study and the smaller study, what you will see is that the relative risk is the same because these studies are very identical in design, but the p-values in 95% confidence intervals suggest that the strength of evidence is not that high in the smaller study. So in other words, p-values in 95% confidence intervals depend a lot on sample sizes. Okay, so I hope that made sense. So to summarize, p-value is simply the probability that the observed value, or a more extreme one, is due to chance. So it is the same conceptually as a type 1 error. Confidence intervals, or 95% confidence intervals, refer to the interval or the range of values within which observed values from 95% of similar studies from a given population would lie. And p-values and CIs should both be reported when you're doing an analysis. Okay, that's it from me.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.